How's it going, everyone? I'm Patrick Schiess, and today we are going to take a look at the information blocking requirements of the 21st Century Cures Act. I am extremely excited to be joined here today with the legendary Wayne Singer. Wayne has been a fixture in the health IT community for many years and knows way more about this stuff than anyone else I've ever met. How's it going, Wayne?
I'm doing well. How about you?
I am doing pretty great myself. Do you want to give a quick intro about you, and then we'll pop into some of this other content?
Sure. I'm currently VP Regulatory Services with Darena Solutions. My background ranges from durable medical equipment to disposable medical equipment, and also I was part of the evolution when even the durable medical equipment acquired software knowledge or a brain behind the system to operate things like OR tables, even the beds that patients are on and the floors. And then I've also evolved into the health IT environment where I started with designing and developing EHRs and have watched that evolve over the history here from the early 90s to current.
Yeah, it sounds like you've got quite a bit of experience in this space.
Yeah, I have the advantage of, I guess, watching the evolution, right, where the dream of interoperability has been around since the early days of meaningful use. And now I see it finally gelling and taking at least the opportunity to take off and be shared by all stakeholders.
That's a really great segue into my first big question for you, and that is, what is the deal with this whole Cures Act thing?
Sure, the 21st Century Cures Act is also, I could say, a accumulated effort from back in the day of meaningful use and other programs. It was signed into law back in 2016 by overwhelming bipartisan support when that used to happen. What that said was it had multiple facets. It included a moonshot for cancer cure. It includes the opioid epidemic and trying to control that from standpoint of when who's prescribing where and when. But the two components that came out of it that's specific to our environment is about health information exchange, and obviously the other counterpart of that is the information blocking rule to avoid obviously any type of barrier to a patient having access to their information in a timely fashion. So it's basically a now a mandated law that has something that people can point to as for behavior modification in all stakeholders.
It sounds like these regulations have been around for a while, so why should we care about this now specifically?
Right. As per any, I guess you could say, mandate that's come out of the government, it went through many different iterations, rulemaking processes, comment periods. And so what began in 2016 is really taking, obviously, until now, or in fact, what starts January 1, 2023, to really go into effect. We look back at HIPAA. 1996 is when HIPAA came a law. It took at least until 2010 before the whole element of privacy, patient privacy acts within HIPAA really gelled. And even now, today, you could say it's a household word. We know what to live by and how to work with patient protected information. The Cures Act is coming through that similar evolution from early adoption to now we're going to put it into a mandate.
Gotcha. So, who should be concerned about this?
Right. Anyone who is in and around patient information from a standpoint of obviously providers who document care and treatment, EHR developers who enable the documentation to be obtained through any of the actions of the providers, health information exchanges where they serve as kind of a clearinghouse or a reservoir for health information as it's temporarily stored and exchanged across the continuum, and even payers as they gather health information for the care and treatment of patients. They're all actors under the Cures Act and really are subject to obviously making it very easy for a patient to access, use, and exchange their information.
You mentioned earlier this concept of information blocking. What does that actually mean? What are some of the consequences?
Sure. Information blocking would be any occurrence where there are either actual um, physical barriers that don't enable a person to be able to gain access, or if there's any other infringement that's put into place, like a cost. If that's too exorbitant to say, I can give you your records, however, it's $3 a page, or any of the, yes, I can give it to you, but because of my timeline, it's going to take me 3 months. Any of those impairments to easy access of their information could be deemed information blocking.
So let's say that I am a patient of a particular healthcare institution and I would like to get my data from them. What would that process look like, or what is the expectation that I should have as a patient?
Right. What is now mandated under the Cures Act is upon request from a patient or their authorized representative, a provider is to make available whatever requested information in a timely fashion. So it's a request to the provider's office, and then they have an ability through their EHR to answer that request by providing an invite to that patient, and the patient can use a application of their choice, a third party app as it's called, to access their information electronically. One of the ways is through what they call the API method, and that's where a patient has a third party app on their iPhone, their Android, and they can actually then request an invite to allow them to go into a their individual record and obtain the information that they're looking for. Any encounter summaries, procedures, any of their information. In fact, as of October 6th, it expands to everything that's more clinical or stored on behalf of the patient, like excuse slips or permission to go back to work. Those are now fair game as well.
Traditionally, a provider might do something like fax a copy to someone, or they might print it out and send it home with a patient. So it sounds like this is quite different, and the expectation should be different.
Absolutely. What they really are looking for is electronic exchange of information so that downstream from wherever this source is created can actually also incorporate that information into their care and treatment plan and not have to worry about reading or looking at a paper and then transposing it into their records, which obviously is a time delay or even can cause errors. So the objective is for easy information exchange, the true interoperability of electronic patient health information from one point of service to the other, and they're enabling the patient to play the critical role of that information exchange process. They're the ones who've got the most vested interest to have their information at that point of care in the quickest, near real-time fashion as possible.
I want to explore a little bit more on something you mentioned earlier about an authorized person or maybe a caregiver. So, who does this actually apply to? Does it apply for newborn babies, or maybe travelers, non permanent residents, or elderly people, or those who may not have like immediate access to technology? Are they still covered, and should they still be able to retrieve their data in these particular formats?
Right. The engagement of the patient is what is really top of mind here. And at any given point, from you could say cradle to grave, that patient, newborn or elderly, is basically entitled to their information. And the means to get it could be through that authorized representative, the parents for the child, the older adult children for the elderly parent who's maybe not techno savvy. That still, that exchange of information, in fact, the younger the patient might be or the older the patient might be, is you could say it would raise the sense of urgency that accurate information is exchanged in that near real time fashion so that that next deliverer of care downstream can be as smart as possible on that patient so there's no redundant testing. Maybe if it can avail additional labs or imaging studies, they're now smarter to know 2 points of a reference, and that care and treatment plan can be developed with a lot more deliberation because they're now more in tune with what the patient's situation is currently.
What about the delivery of sensitive medical information? Let's say that I have some test results that have not been properly interpreted by a provider yet, and I get access to that data early. Are we worried about some of the effects that that could have on the patient's care?
Yeah, that's right now one of the early pinch points that people bring out quite often about the information blocking rule. Essentially, one, I guess, covenant you must remember is it's upon request. So if the patient is not aware of the results that are in, more than likely they're not going to request it up front. The provider can obviously use judgment still to say what consequence would be of knowing, the patient knowing this information. There are 8 reasons in the Information Blocking Act why a provider can, in a sense, not be held as an information blocker. One of them is in the psychotherapy notes section. Those are actually off the board. They can be withheld by the provider. They can be shared if indicated, but they also can hold them back because of potential harm to the patient in sharing that information. Now, there are other reasons that a provider can hold back information for. There's content and manner, and we can, on another video, go through the 8 reasons. But essentially, what it's meant to be is the patient should have access to their information in a timely fashion. And again, the provider can say if something's requested and yet it's too sensitive, then they can take additional measures to notify the patient of this information, whatever that might be. Come in and talk to us first, or any kind of information exchange that could really reduce the potential of emotional harm to the patient. It's still up to the provider to use their clinical judgment. And again, since it's upon request, that will minimize, let's say, information going out that's not ready for patient consumption.
You mentioned psychotherapy notes. That also makes me wonder what specialties and subspecialties does this actually apply to? Are there any limitations or restrictions, or where do we draw the line?
Yeah, there isn't a line to draw. It's if you are a clinician documenting care of a patient in any form or fashion. So that's, as I would call it, from behavioral health to podiatry, what I kind of jokingly call it head to toe. Um, Small practices, large practices, they're all included. There is no line per se to say, well, you're a solo practitioner and you see only 10 patients a day. If you see patients, you document the record, you're basically under the information blocking rule to exchange information upon request of a patient or their representative.
It sounds like there's a lot of very intricate knowledge to be had about this particular information blocking requirement. If I wanted to read more about this or maybe validate my own understanding, where would I even go to look for this?
Yeah, the ONC has I guess, have been very busy. And so healthit.gov would be the place to go. ONC has got, from that link, you'd see information blocking webinars, blogs, fact sheets, any of the, even some of the clinical specialties. If you're a member of the American Academy of, they're putting out even their information sharing. But pretty much if you look at the references through all those, they link back to the healthit.gov site where ONC has been sponsoring multiple facets of education on the information blocking rule, as well as they've put out a new portal that is the place where you go to submit information blocking claims. It makes it very easy. You can quantify it. You can also submit it anonymously. So they're taking this very serious all the way from the education to the implementation, as well as an ability to file claims for information blocking or suspected information blocking.
Let's change gears a bit. I have been compiling a list of some of the most common questions that we have received at Darena Solutions about what applies and does it necessarily need to be something I'm worried about. And I'm just going to quick fire go through this list, and I would love to hear your perspective on some of them.
Sure.
The first one is I run a small EHR platform that only services a few providers. Does this still apply to me?
Yes. Again, even if you're not certified under the what's called the 2015 edition certification for EHRs, you are a health IT provider and therefore an actor. And then your providers who are documenting care and treatment of patients is considered the actor under the provider provision. So, yes, absolutely, it applies to you.
Okay. Who is actually policing this? Should I be worried?
Yeah. Well, I would say yes, because over the years, the CMS has done these meaningful use programs, PQRS. It's all evolving. The value-based programs like MIPS and a lot of the different APM or ACO models that are out there. CMS has looked at it that they've spent, the recent article I read, they've spent $31 billion on the I guess you could call it incentives to meaningfully use and meaningfully exchange information over the years, back starting from 2011 and up to now. So now they're at a point where they're saying the industry, I've tried to have you do it yourself. Now I'm going to put a little bit more of an emphasis on it with this Cures Act. It's a law, and ONC is policing it from the EHR health IT developer side, and Health and Human Services, the Secretary of Health and Human Services through the Office of the Inspector General will police it from the other actor perspective, providers especially. We're expecting them to have their announcement of how they're going to litigate it, let's say, at the end of this year. They've made several announcements at several meetings that ONC was first out of the block. The health IT developers, they're saying penalties can range as high as $1 million. Won't happen that way out of the box, but they're serious about infractions. And so ONC is policing it from the health IT developer side, and Health and Human Services has charged the Office of Inspector General to police it from the provider side.
Are there any implications for Medicare?
Yes, in fact, I might call it almost piling on, but Medicare has come out recently and said they're also looking at civil monetary penalties that would be placed on providers who are information blocking to the Medicare, Medicaid beneficiaries. So there's the information blocking, you could say, covers all payers, all, even you could say if a patient is concierge medicine, paying themselves, that's still covered. But so Medicare, Medicaid is expanding to say they're going to look over the shoulders and see if the infringement was specifically to one of their beneficiaries, that they will all actually put their own penalties in place.
Gotcha. All right. Next question. As a provider or an EHR, how quickly do I have to be able to provide the records upon request for a patient?
Right. Well, it's on a timely basis is the kind of that catch-all phrase. It used to be under HIPAA, you had 30 days to do it. This information blocking and the Cures Act is really condensing it to be that as soon as practical. There can't be these barriers of I'm busy, I'll get to you in eventually the whatever time. The best way to look at it is an EHR and or providers should establish an actual policy that says we do support your requests for information. We will honor it in and then put a 3 to 5 business days. Business days to avoid, this is Friday afternoon at 3 o'clock and I want it for Monday. Be careful with those, or holidays. So if you have it published that you have this set expectation, I will be able to honor your request in X amount of time, then that also would be going a long ways to avoiding being called information blockers because you've set the expectation, you've made them aware of it. People are posting things in exam rooms, in the waiting rooms. They're actually, I've heard of people actually including a flyer or just what they call the stuffer in the bills that they send out. They're putting it as part of their reporting when the patient's on hold for, calling in for whatever they want to do, a new appointment. It says instead of music, they're saying We honor the new information exchange policy. However, please allow, again, 3 to 5 business days for us to fulfill your request. Setting the expectation is what would get most people out of trouble.
Sounds like it might be beneficial to be more proactive rather than reactive.
Absolutely. This is, again, from an ONC and Health and Human Services perspective, they actually wanted this to go into effect November of 2020. They actually pushed it out because of, again, trying to reduce the burden to providers and health IT developers. And that's why the first of the process for the health information exchange started April 5th, 2021. Even that was kind of a soft launch, and that had a provision that you can exchange information clinically using the new US core data for interoperability data elements. That was an advancement over what we had in the past. But even then, the enforcement was more, again, like I say, a soft launch all the way up to October of this year, just a few weeks ago, that it was going to expand from the clinical data perspective to all health information that's what they call EHI, that's stored in a medical record on behalf of a patient. Again, the excuse slips, billing information, living wills, power of attorney. Those things could be available and would be available upon request. So what's happened is this should have gone into effect a year and a half ago, and now it's coming into effect as of January of 2023. So they're really serious. And, they've said, we've given you extensions. We're all talked about internally how some of these mandates have been, as we called it, kicked down the road. It's kind of a just kidding, as I call it. But this time, I think they've given the extensions, and now the January 1 will be that, official launch, and essentially, where people could be called out as information blockers if they haven't changed their methodology.
Let's say I am an EHR or a provider and I already have a patient portal for this kind of thing. Does this apply to me?
Yes, because what they've done is responded to patient complaints, and that, especially in the Medicare services group, you can imagine that Medicare beneficiary who has a dermatologist, an orthopodist, primary care specialist, a cardiologist, has been to 1 or 2 hospitals. Each one of those points of service and each one of those providers is saying, please go to my portal for you to see your information. Each little silo of information exists out there. It's also another username and password that they have to remember, consider. That complaint is what CMS responded to add another aspect of this, these API capabilities for a patient to be able to obtain their information using a third-party app of their choice. So in other words, the portal is the patient's app that resides in whatever, PC, smartphone, whatever they want to use. And then they can now request information from their cardiologist using EHRA, their internist using EHRB, their hospital who's using another third, major EHR of their own. And now they can have this longitudinal record that's consolidated on an application that they have. That's the access, and then use it so they can review it, understand it, but more importantly, they can exchange it with the next provider downstream so they have a better snapshot of the most current element of this patient. What's their meds that they're on? What's their latest treatment? What's their status post whatever, some procedure that's important for that next provider to know. It's important also to include dentists in this process as well. It's another caregiver, but they add pharmacists, labs, pathologists. So everyone can communicate now through this process.
I feel like everyone probably has their horror story of the time that they got a scan done at one, maybe an urgent care facility, and they ended up needing to get a referral to a hospital or something like that, and the hospital was not able to see that particular scan, so they had to get it again, which is, in some cases very invasive and can be costly. So that certainly seems like this would be a good thing for just everyone, like overall.
Right. And even if we can't minimize the repeat, blood draws or the repeat imaging, if that next provider has the benefit of the results of the previous one, that 2 points, 3 points of data is very important in the care and treatment. If someone sees a value of 12 on their most recent lab and then realizes the last four labs were the same 12 or in the same range, that might alter their care and treatment plan because they see that's more of a normal for that patient rather than be alarmed that that's high and out of whack. So again, that makes everyone smarter, even if they, again, the ideal is to minimize the repeat studies if they're close enough together to be clinically relevant. But anyone who's ever had an X-ray always hears a radiologist says, "Were there any other X-rays?" They love prior films for comparison. That dot on the film, was it there 10 years ago, or is this something new? This is what we're trying to do: is break down that silo where information is in one place, very solidly documented, but over the next place, there's no exchange. And so therefore that patient is almost treated brand new every time they walk in to a new institution or a new point of service. Interoperability is what this is all about. And the patient, again, is that mode of easy transfer because also they're the ones with the biggest, greatest vested interest in making sure they don't get poked two or three extra times, or all the information is now provider validated and in the hands of their next point of service.
It sounds like a dream. Maybe a dream
Well,
come true for some people, and maybe a nightmare
it,
for others.
it has been that holy grail forever. Meaningful use was the first term. And, that truly was trying to say, are you meaningfully using the information, not only for yourself? That was the first step, going from paper to electronic. But then now that it's electronic, can we share amongst ourselves? Initially, the barrier was EHRA didn't talk to EHRB. They were disparate of one form or another. Then we opened up with the ability to share things called a CCDA, which was a common language terms or a common expression of how clinical documentation could be rendered in a electronic document that with certification, EHRs now were in a sense agreeing to accept CCDAs from other EHRs and be able to not only bring it in and consume it from a machine readable standpoint, but also render it for a human readable standpoint. That is that interoperability for bi-directional exchange. Um, that's what we're growing to. And then obviously this is the next mandated step where we're enhancing that information exchange by another standard, which is the FHIR standard, another way to render clinical data in a very easy to use and exchange process that, again, has been around for many years. It's now coming of age and is now finding its way into the health information exchange network.
So we talked about the dream. Let's talk about the
Yeah,
nightmare.
yeah,
Maybe as a provider or an EHR, I just absolutely cannot make this happen, especially by the deadline. Is there any way that I can get an extension or maybe opt out of it? Like, what are the risks involved in this particular situation? Because it sounds like the stakes could be potentially high if there's like $1 million penalty.
right. Well, I would say the extension potential is very minimal to non-existent. There might be an ability to have a temporary game plan that says, I didn't do it by January 1, but here's how I'm going to do it in 3 weeks or less. There won't be 3 months or more. Even 3 weeks might be a little extension, a little on the edge, because ONC and Health and Human Services are saying this started in 2016. We had many iterations where they came out to stakeholders. They didn't just do it in a vacuum. They had panels of providers, of patients, of nurses, of all walks of providers giving their input. They went through and diligently covered comments to say, here's why I like what you said, here's what I don't like, and here's what we're going to settle on based on everything we heard. Some people won, some people lost, but overall it was a consensus. And so over the time, even going back to when it was supposed to start, and they go, all right, we heard you. It was going to be a little bit of a stretch and a burden, and we certainly don't want to infringe on the quality of care of the patient. So I'll give you this year and a half extension. So I think for those who aren't able to do it, it's a too little, too late. It's not, again, unless you have been in the proverbial, hole in the ground where you haven't heard anything. There's been so many different, again, webinars, emails, blogs. Even the New York Times came out with a program, with an article on it. All the associations of, like I say, American Academy of, have put out and have on their website a special tab now which covers the general information blocking rules, and they always funnel it down in what does it mean to us, the cardiologist, the podiatrist, the orthopod, whatever the specialty. They have that statement, and really the bottom line is you're in it. You might as well adopt it. Call your EHR, talk to your EHR, see what they're doing to make the provision. It should be electronically enabled so that it is easy to do. It should not deviate too much from your normal everyday workflow. And in fact, as it really is going to go to the full end of it, you are responding to information upon request to share with the patient. But really, the word interoperability should be you should expect to get information back from that patient as they're being that, that the clearinghouse of them of their own care and treatment. So bi-directional exchange is where this will ultimately give in or play out, especially when we include health information exchanges, health information networks. They're part of the actor profile as well. So again, my advice would be if you're not capable of fulfilling it, there are third-party applications. Darena is one of them that you can actually interface with and immediately be in compliance. So even the fact that internal capability might be limited because of resources and all the things going on, there are simple interfaces that can take place that will enable you to be fully compliant with the letter of the law from an information blocking standpoint.
That sounds awesome. Thank you so much, Wayne, for clarifying some of those things. I want to go ahead and start wrapping up. And
Okay.
to do this, I want to leave the listeners with 3 top takeaways. What would you say if anybody could take anything from this particular video? What should they remember?
All right. Well, I also subscribe to the no one of us is as smart as all of us phenomenon, but I guess collectively looking at this is the first takeaway is I would say look at the cures mandate specifically to health IT as a real must do. It's not going to be, the can won't be kicked down the road. So take it seriously. That's the first takeaway. The other one is to embrace the interoperability benefits that come out of this. Now, how would everyone benefit by exchanging information in what I would hope is that next holy grail is the near real time exchange of information. I need it. I have it right at my fingertips. That's the other thing. And then obviously education of everyone involved. That would be the provider, the patients, the EHR staff and development. What is the importance of what role do you play in the information blocking mandate, and how do you enhance all the stakeholders around you?
That's awesome. Thank you again so much, Wayne, for your time and for sharing with all of us. I really appreciate it.
All
And I'm going
right.
to go ahead and wrap this up. Thank you so much for watching, everyone. Stay safe, and we'll see you in the next one.